Welcome to the deep dive. We're here to, cut through the noise on big topics and give you the essential knowledge fast. Today, we're focusing on a really significant global health issue, sickle cell disease or SCD.
Yeah, this is our deep dive into probably the most common serious genetic disease across the whole world. You might hear it called drepanocytosis or anémie falciforme, especially from French sources. But our goal today is really to understand the mechanics of this illness and also the huge scientific shift happening right now towards finding a permanent cure.
And the impact, the numbers are just staggering when you look at them. We're seeing data that shows over 300,000 babies born with the full disease every single year.
That's right. And globally, estimates put the number of people living with SCD at around 4.4 million. That's a huge number of lives affected.
So to really get our heads around this, we have to start right at the beginning with the genetics.
Exactly. SCD is what's called an autosomal recessive disorder. It comes down to one single tiny mutation on the hemoglobin gene, the HBB gene. Now, to have the actual disease, you need two copies of that mutated gene. We call that being homozygous, often written as SS.
Right, SS for sickle cell. But there's this other crucial piece, isn't there? The carrier state?
Yes, and this is key to the whole story. If you inherit just one copy of the mutation you're heterozygous, or SA, you carry the sickle cell trait. These individuals are generally healthy, mostly without symptoms. And that, as we'll definitely get into, is why this gene persists so widely.
Okay, let's unpack that mutation at the molecular level. The sources really detail this. It's like a single typo with massive consequences.
It really is. A single base substitution in that HBB gene. That's all it takes.
Just one letter change.
One letter. At position 6 of the beta-globin chain, the normal amino acid is glutamate. It carries a negative charge. This mutation swaps it out for voline, which is a polar, it doesn't like water.
Huh. So that tiny change messes with the basic physics of the hemoglobin protein inside the red blood cell.
Completely. This altered protein is hemoglobin S, HbS. And the critical thing is oxygen. When a red blood cell carrying HbS releases its oxygen in the body's tissues, well, that's when the trouble starts.
Because the HbS doesn't like being in the watery cell environment without oxygen?
Precisely. It becomes much less soluble. It starts sticking to itself.
It doesn't just thicken, it actually crystallizes.
It polymerizes.
Yeah.
It forms these long, rigid, rod-like fibers inside the red blood cell. And it's this physical process that forces the normally flexible, disc-shaped red blood cell into that characteristic crescent or sickle shape, the drepanocyte.
And the impact on the cell itself is just brutal. Normal red cells live for about 120 days, right?
Right, but these sickled cells are fragile and stiff. They get destroyed incredibly quickly. Their lifespan is only maybe 10 to 20 days.
Wow, so that leads directly to anemia.
Chronic hemolytic anemia, yes. That's the baseline problem, not enough healthy red blood cells. But the immediate danger, the acute problem, comes from that rigidity, the stiffness.
Because they can't squeeze through the tiny blood vessels.
Exactly. They get stuck, especially in the small capillaries. They pile up, block the flow.
Which brings us right to what seems like the defining feature of SCD. The pain. Intense, debilitating pain.
Absolutely. Historically, before we really understood the mechanism in, 1910, the disease was known by its pain. In parts of Africa, local names often refer to these terrible crises, describing sensations like bones exploding or being crushed. That tells you something about the severity.
And the clinical term for this blockage is vaso-occlusive crisis, or VOC.
That's it. The sickled cells obstruct blood flow in the small vessels. This can happen anywhere: bones, abdomen, kidneys, even the brain.
And that blockage cuts off oxygen.
Leading to ischemia, lack of oxygen in the tissue, and eventually necrosis, tissue death. That's the source of the intense pain.
And these VOCs aren't rare episodes, are they? They're common.
Oh, extremely common. They're the #1 reason people with SCD end up in the emergency room. Something like over 90% of ER visits.
The sources mentioned something interesting about treating that severe pain involving morphine metabolism.
Yes, this is a really critical point for patient care. For moderate pain, hydration, rest, warmth can help at home. But severe crises often need IV opiates like morphine in the hospital.
And the metabolism difference.
Studies show that patients with SCD metabolize morphine somewhere between 3 to 10 times faster than people without the disease.
Wait, 3 to 10 times faster? That's huge. That must completely change how pain relief works for them.
It does. It means they often need significantly higher doses or more frequent doses to get the same level of pain control.
And has that difference historically caused problems like misunderstandings in hospitals?
Absolutely. Historically, this faster metabolism wasn't always understood or even acknowledged by clinicians. So a patient asking for what they knew was a necessary higher dose might unfortunately be viewed with suspicion, accused of drug seeking.
Instead of recognizing a genuine physiological need, that's terrible.
It led to undertreatment, delays in care, and added a layer of distrust and stigma to an already incredibly difficult situation.
Okay, so beyond the pain crises, what are the other major life-threatening complications?
Well, the second most common reason for hospitalization, and actually the leading cause of death in SCD, is acute chest syndrome, or ACS.
What does that involve?
It typically presents with chest pain, fever, difficulty breathing, and you see infiltrates on a chest x-ray. It looks a bit like pneumonia. It can be fatal in 1 to 5% of cases and often requires urgent blood transfusions.
And then there's the spleen. It gets damaged quite early.
Yes, the spleen's job is to filter out old or damaged red blood cells. In SCD, it's constantly working overtime removing sickled cells. This often leads to damage and scarring early in life, resulting in functional asplenia. The spleen basically stops working properly or at all.
Which makes people more vulnerable to infections, right?
Exactly, serious bacterial infections. But we need to distinguish that chronic spleen damage from an acute splenic sequestration crisis.
Okay, what's it?
That's a sudden, massive emergency. Red blood cells rapidly get trapped in the spleen swells up dramatically, and the amount of hemoglobin in the circulation plummets very quickly.
That sounds incredibly dangerous, like internal hemorrhaging into the spleen.
It is. It can lead to hypovolemic shock from low blood volume and death within hours if it's not treated immediately with transfusions. It's a true emergency.
And you also mentioned stroke risk, particularly in children.
Tragically, yes. Stroke is a major risk starting as young as age 3. Nearly 10% of children with homozygous SCD under 18 might experience a stroke. In kids, they tend to be ischemic strokes caused by blockages. In young adults, hemorrhagic strokes caused by bleeding become more common.
This whole clinical picture is devastating. But if we pull back, the reason why this mutation is so common, that's tied to malaria, isn't it?
It is. It's one of the most striking examples of evolution in action, really. If you map the global distribution of the sickle cell allele, it overlays almost perfectly with areas where malaria, especially the deadly Plasmodium falciparum form, is or was endemic.
And this is where the heterozygous advantage comes in the carriers, the SA individual.
Exactly. People with just one copy of the sickle cell gene, the SA carriers, have significant protection against severe malaria. We're talking maybe 60 to 80% protection.
So in places with high malaria rates, carrying one copy of the SCD gene was actually a survival advantage.
A huge advantage. It's a classic case of balanced polymorphism. Natural selection favored keeping this otherwise harmful gene around because, in the carrier state, it protected against a more immediate killer malaria. That selective pressure is why the trait frequency can be so high, like 10 to 40% in parts of equatorial Africa.
So evolution's tough trade-off. One copy helps you survive malaria, but 2 copies give you sickle cell disease.
Precisely. And this brings us to the importance of environment and social factors. It's not just genetics. The severity of SCD, how it manifests, is heavily influenced by things like poverty, nutrition, access to clean water, even air pollution. These can all make things worse.
The sources really highlighted this socioeconomic disparity. That UK stat was stark: 58% of hospitalized SCD patients coming from the lowest income group.
Yeah, it shows how intertwined health outcomes are with social determinants. Access to consistent care, good nutrition, stable housing, it all matters hugely.
And we touched on this earlier, but the history includes significant issues with racism and stigmatization, especially regarding pain management.
Definitely. The experience, particularly for Black patients in the U.S. in, say, the 1980s, trying to get adequate pain relief during a VOC was often marked by suspicion and inadequate treatment due to misunderstandings about the disease and, frankly, racial bias.
That faster metabolism wasn't understood, the pain severity wasn't believed.
Right, leading to delays, insufficient opioid doses, and immense suffering that went beyond the physical pain. It highlights why understanding the social context is just as vital as the molecular biology.
And this context even plays out in public health policy, like with newborn screening.
It does. You see different timelines. The US and UK implemented universal newborn screening relatively early, widely adopted by 2006.
And the impact was huge, right? Because they could start preventative treatments immediately.
Massive. Identifying babies at birth meant they could start prophylactic penicillin very early. There was a key study on this that was actually stopped early because the reduction in severe infections and death was so dramatically clear.
Yet, In other places, like France, it took much longer for universal screening to become standard practice, even though they had targeted screening earlier in some regions.
Yeah, in metropolitan France, despite having systems in the French Antilles since the 80s, nationwide universal screening wasn't fully systematized until just recently, 2023, 2024.
Why the delay there?
Part of it stemmed from earlier debates about cost effectiveness, whether it was worth screening the entire population versus just targeting groups perceived as high risk. It shows how policy decisions can lag behind the science, sometimes for complex reasons.
Okay, let's shift towards management and, importantly, hope, because the prognosis has improved dramatically.
Oh, immensely. Before the 2000s, it wasn't uncommon for patients to die before age 50. Now, in developed countries with good access to care, the median life expectancy can exceed 60 years.
What's been the key driver of that change?
Consistent care is foundational vaccinations against infections, good hydration practices. But the big game-changer medication has been hydroxyurea.
Sometimes called hydroxycarbamide.
Yes, same drug. It really became a cornerstone of treatment around the 2000s.
How does hydroxyurea work? What does it actually do?
It does something quite clever. It stimulates the patient's body to produce more fetal hemoglobin, HbF. HbF is the type of hemoglobin babies have before birth. It's perfectly functional, and crucially, it doesn't sickle. It actually interferes with the polymerization of the HbS.
So more HbF means less sickling, fewer crises.
Exactly. It reduces the frequency and the severity of the vaso-occlusive crises, reduces hospitalizations, and improves overall quality of life. It's
Yeah.
been a true life extender.
And alongside medication, there are important lifestyle factors too.
Yes, simple but effective things patients need to be vigilant about. Staying very well hydrated alkaline water is often recommended. Staying warm, because cold can trigger crises. Avoiding tight clothing that might restrict circulation. And avoiding high altitudes, generally above 1,500 meters or about 5,000 feet, because the lower oxygen levels can trigger sickling.
But now the conversation is really shifting beyond just managing the disease to actually curing it.
That's the really exciting frontier. For a long time, the only potential cure was a bone marrow transplant, usually from a healthy, matched sibling.
And how successful is that?
In children with a good match, the success rates can be quite high, maybe 85–90%. But it's a very intensive, risky procedure with significant side effects. And the biggest limitation has always been finding a suitable matched donor. Most people don't have one.
Which is why gene therapy is generating so much excitement.
Exactly. This is where the science has moved incredibly fast. We saw successful clinical trials reported as early as 2014. And then, in early 2024, landmark approvals came through in the US and Europe for new gene therapies, like one called exagamglogin autotemcel.
How do these work? Are they modifying the patient's own cells?
Yes, that's the key difference. They typically involve taking the patient's own bone marrow stem cells, genetically modifying them in the lab to correct the defect or to boost fetal hemoglobin production, and then transplanting those corrected cells back into the patient after clearing out the old marrow.
So it potentially offers a cure using the patient's own cells, avoiding the donor issue.
That's the promise. It represents a fundamental shift from lifelong management of a chronic illness to a potential one-time curative treatment.
Okay, so wrapping this all up, what's the big takeaway here?
I think it's that sickle cell disease is this incredibly complex interplay of genetics, human history, environment, and society. You have a single tiny gene change, preserved because it offered protection against malaria, which then created this enormous global health challenge. It's a profound story of evolutionary trade-offs.
And we've seen huge progress in managing the disease, dramatically improving lifespans, especially with treatments like hydroxyurea.
Yeah, the science of management has come so far. But the access to even that standard care, let alone the cutting-edge stuff, is still so unevenly distributed around the world. Socioeconomic factors remain a massive barrier.
Which brings us to a really challenging final thought, especially with these new gene therapies.
Right. We now have these potentially curative technologies. They are scientific marvels. But they come with extraordinary price tags, millions of dollars per treatment currently.
And the vast majority of people living with SCD are in low-income countries, regions that often struggle to provide even the basic, established standards of care.
So the question it leaves us with, the ethical challenge for all of us, researchers, companies, governments, global health organizations, is this. How do we bridge that gap? How do we ensure that these incredible genetic breakthroughs, these potential cures, become accessible and affordable for the populations who bear the greatest burden of this disease? That's maybe one of the biggest questions facing medicine today.